Dear colleagues, I'm really pleased to speak about one field that I am working for many years, so I feel a little bit more comfortable speaking about cardiac rhythm management devices, which is really a steadily evolving field. And here is my disclosures. And allow me first to present the history of pacemakers development. As you have the opportunity to see here, not only the technology has changed during the last 50 years, even 60, but the size, of course. And I got the opportunity immediately to go here on this slide and to say to you, pacemakers and pacing techniques are very effective to save lives and to improve the quality of the life of the patients. Please, take as an example sinus node disease. It is class 1 indication, level of evidence B, for the improvement of the patient's quality of life. Take as an example the complete heart block. It is really so important nowadays to see the patients living normal, regular life because the pacing support. So we have done during the last 60 years a tremendous progress in treating patients with bradyarrhythmias. No doubt, nobody doubts. And the cost of pacing is really very high. Talking about an evolving area, undoubtedly we have to look backward the near past. And this photo is a classical one which shows an external pacemaker in the year 1957. Main developments in pacemakers since 1958 to 2014. Pacing and sensing capabilities. Now, from 5 to 7 parameters. 30 years ago, we are now programming nearly 35 parameters in the advanced pacing systems. Dual chamber sensing and pacing. It was another development. Rate responsive pacing, multi-programmable pacemakers, diagnostic features. This is very important. Nowadays, these implantable devices are not only pacers, not only are doing so many in pacing the patients, but also in diagnostics. All these advanced systems have, as you know, Holter monitoring capabilities, and we have now a very clear understanding about especially tachyarrhythmias and their incidence. As you know, we have the opportunity now to interrogate to some degree and to program the pacemakers using telehealth features. And of course, we have a very, very small size in our pacemakers. Again, here is the history. That was 60 years ago, the whole story, and progressively is becoming very small. And don't underestimate the fact that now we have MRI compatible pacemakers. I wrote an editorial a few years ago saying, is the use of non-MRI compatible pacemakers a malpractice? Believe me, in 10 to 15 years from now, most of the countries are going to use 80% of their systems MRI compatible. Already in some countries, the majority of the implantable devices are MRI compatible. What about small pacemakers, leadless pacemakers, or miniature pacemakers? Here I am very sensitive. Why? Because I had published this paper in the year 1991 in a German journal in English language, edited by Richard Sutton. Unfortunately, this journal was not during this time in the Medline, but however, I had the opportunity to present this title, A Miniature Pacemaker Introduced Intravenously and Implanted Endocardially, Preliminary Findings from an Experimental Study in Dogs. We had very good results, and during this time, I was presenting the idea in different congresses, saying everything is dependent from the capabilities and the capacities of the batteries. If the technology will improve, we will have the opportunity to enjoy leadless, actually I said miniature pacemakers. Here is the progress. This is a Medroni Micra, which was developed 25 years later, and you have the opportunity to see here how the device is implanted. I had the opportunity to implant such a device for the first time in my department, for first time in Greece 2 days ago in Creta, and I enjoy very much to see my idea 25 years ago to be a reality. It is really a very, very specific feeling. In this video, you have the opportunity to see how the device is placed, how the device is replaced, if you like, to achieve a better threshold. But again, as I said, yesterday, 2 days ago, when I had the opportunity to implant in my department the first device, the technique was amazingly easy, as I had envisaged 25 years ago. And you have the opportunity to place the device there. The threshold was very nice. It's very nice. It's about 0.8 millivolts at 0.25 milliseconds duration. And here is the X-ray from these implantations. And yesterday I had the opportunity, indeed, to compare the device that I implanted yesterday, 2 days ago. It's not this device, it was a similar one, with this device that I developed in my laboratory 25 years ago. I missed the patent. I missed about 100 million euros, but never mind. This is the life. So, what about leadless pacemakers? As you like to listen from me, the benefits and the expected potential advantages from the leadless pacemakers. Less invasive, better cosmetic effect. Of course, still we have the problem that we are using only these devices for VVI modes, but less leads are reducing the possibility for leads insulation breaks, etc. Recently in Barcelona, we are here to present the highlights from Barcelona. So recently in Barcelona, we had the opportunity to listen about the batteryless pacemaker. Indeed, this is a very simple idea, as the automatic watch is taking the energy from the movement. In the same way, we are trying to see if a pacemaker could be powered by the movement of the heart. Very simple. This idea indeed exists during the last 30 years at least. But a very nice Swiss man, or woman, I don't know, I think it was man, decided to make the idea a reality, and it seems that it's working. You have the opportunity to see here how the device, the concept of the device, and the device is working. The batteryless device takes energy from the movement of the heart, and it has a little bit more to continue pacing even if the heart stops. So this is the basis of this idea. What about ICDs? First, let's recognize the reality. ICDs are running now their 30 years of life history. And everybody knows here that for the secondary prevention, it is class 1 level of evidence A. Nobody doubts that somebody who had suffered already an episode of sudden cardiac death should be protected by these devices. But these devices are very easily used in those patients with ejection fraction of less than 35%. One level of evidence A, clear. The usage of ICDs is expanding. And here, again, the history. He is Michael Mirovsky, and the engineer that they used to work together. Unfortunately, I cannot recall the name of the engineer, but Michael Mirovsky was the physician who had the idea to make the device, and this device was used in a dog, as usually, and the dog was fibrillated and then successfully defibrillated. It is also a video showing the dog fibrillated and then defibrillated successfully. And what about the size of the ICDs? The size is getting smaller and smaller. And of course, it is much more better if we had the opportunity to enjoy a very small ICD placed subcutaneously. And this is the idea for the subcutaneously placed ICDs that now are clinically available. And I'm sure that you know that the idea works, still with some problems. The main problem is that these devices have not the opportunity to pace the patient. But the company is quite optimistic that they will give a solution here. So, subcutaneously placed ICDs are here to stay. And if I would like to pass to you a message, my dream, my vision, but not only my vision, but I'm sure that many others have the same vision, is to see a very small ICD in the size of the coin placed subcutaneously just in the case to treat the huge mistake of the nature. And the huge mistake of the nature has a name: fibrillation, ventricular fibrillation, even atrial fibrillation. It's unthinkable, even this marvelous muscle, namely the heart, to be totally disorganized in a few milliseconds. It's amazing. None of the other muscles of the human body is such paralyzed in milliseconds. Only the most important muscle. So this is a huge mistake of the nature. And we have the mission to fight the mistake. And the only solution is the subcutaneously placed, very small ICD. I'm very optimistic that in 15 years from now, the problem will be solved. So, the ideal candidate for subcutaneously placed ICDs are here. And what about the wearable defibrillators? It seems as an idea working. Okay, it's not the easiest, but there are some very good results from different trials presented recently in Barcelona. And it seems that this wearable defibrillator could be used as a bridge device in different cases. Future of ICD therapy: reducing inappropriate therapy, remote monitoring and diagnostics, extravascular ICD therapy, new hardware and combinations. Let's speak in very brief about CRT, cardiac resynchronization therapy. It is becoming a very common clinical therapeutic modality. LBBB with QRS duration of more than 150 milliseconds, it should be treated with this device, this system. Class 1 level of evidence A. Of course, the main question is, Do we have to use pacemakers?
Oh my God. Your time is up.
Give me, if you like, two minutes, and I will finish in 2 minutes.
We need 3 minutes more, please.
Yes, and it seems that dual chamber or 3-chamber ICDs are much more common. Okay, it's clear that nowadays we are using a lot of such devices, but speaking about new achievements and new ideas, I would like to highlight here, as we are talking about highlights in cardiology, the quadripolar pacing. Now we are using quadripolar systems to achieve a better coordination of the atrial mask, of the ventricular muscle and atrial muscle. What about MRI conditional systems? As I said, these systems are here to stay, and in 5 to 10 years from now, in many countries, most of the systems implanted will be MRI compatible, because we need to use MRI for many reasons in AIDS patients. MRI devices presented here. Most of the companies at the moment are developing this kind of devices. And allow me to say a few things about the subcutaneously placed monitors. Another huge involvement in the CRM devices. Reveal. That was the predecessor a few years ago, and now this is very thin. This new version of Reveal, which is placed just in a few minutes. It's like to inject something, okay? We had the opportunity to see the development of Reveal, and it is a marvelous gold standard for many arrhythmias and to investigate syncopal attacks. Because, as you know, syncope is something paroxysmal, and this is the only device to see what is happening, but also to investigate the atrial fibrillation incidence, especially after ablation. So we have fantastic developments in implantable loop recorders. Fantastic developments in implantable loop recorders, and we are very happy. And telemonitoring. This is the future. You know, everything in 20 to 30 years from now will be tele. And already, many of the devices are follow-up using telemonitoring. So, dear colleagues, personally, but I'm sure that yourself too, I'm very happy that we are serving such a marvelous specialty, namely cardiology and especially arrhythmias, because we have done so many achievements during the last 60 years. I'm looking at the future very optimistically from the point of an electrophysiologist. Thank you very much.
Any questions from the audience? Prof, you know, when you, anytime we have anything development in the field of anything in the field of cardiology, you're always concerned about safety and efficacy and effectiveness. Also the training, to keep the training, to keep the skills. I don't know how with this new invention coming, how we able to keep safety and efficacy of this. That's at least my concern, because I'm in charge of training with fellows. That's my concern.
Could you help me to understand what you mean safety?
Yeah, you know, this new devices is coming in the field just now. You know, hasn't been through lots of randomized clinical trials. I mean, maybe you are expert in the field.
Which device you mean?
The device you mentioned here for the
diagnostic or therapeutic?
No, therapeutical. You know, the
like
the leadless, the batteryless, and these ones. Okay.
Okay.
We have not compared to the standard one.
Okay.
Yeah, that's what I meant.
Okay. Talking about, I would like to touch upon two things that you raised. One is the cost effectiveness, and the other is the safety. It's true that from all these devices presented, 2 devices need special evaluation. One is the subcutaneous place ICD. This is, of course, no doubt. We need very close analysis. And the other is the leadless pacemaker. At the moment, one of the companies, namely Medtronic, is running a large clinical trial to evaluate the safety of the device. Talking about cost effective, but I agree with you. Yes, I agree totally with you. We need to see at least 2,000-3,000 of these devices, follow up by 5 years, especially about thrombogenesis, and about the stability of the device to remain there. Talking, however, as I'm talking to many physicians, I would like to say something else. Please don't be trapped by different politicians and journalists to believe that a treatment with such a device is not cost effective. It's the opposite. One of the most cost effective treatments in cardiology nowadays is ICD and pacemaker. If you see the longevity of the device and how much effective, have you imagined how much effective is a pacemaker for somebody with complete heart block? 100% effective with practically 0 complications. There is not any pharmaceutical therapy such much effective without complications.
Panas, I agree with you about this. But regarding the leadless pacemaker, just for technicalities, do you choose the side, or when you choose the side, the threshold, and then you change it, remove it, and then put another side of the ventricle? I mean, is it easy?
It is easy.
Okay,
very easy.
Any perforation can happen while you are moving something from the ventricle, and then is there any risk of perforation or
as you are very experienced, anyone who works into the heart has some possibilities to perforate something. Okay, no doubt.
Is it only one VBI? Is it VBI only?
Yes, it's only VBI.
Still now VBI.
Yeah.
Okay.
Dr. Panas, what about ICD paradox?
ICD?
Paradox.
Paradox? ICD paradox? What do you mean?
I have written about increased mortality.
Increase the mortality?
Yes.
Okay. To give such an answer is easy. ICDs don't increase the mortality. However, you could be referred to one case, or 2 cases, or 3 cases that something happened, probably one device for X reasons had defibrillated somebody without any reason, and something has been developed. But this is just cases, so few cases that they don't disturb at all the beneficial rates and indexes of ICDs. ICDs, somebody, philosophically talking, could raise another issue, which is real, saying, excuse me, are you sure that ICDs implanted in patients very ill and very old are not leading to discomfort situations as the patients have not the opportunity to die peacefully? Yeah, this is a real issue for philosophical discussion. Sometimes, in some cases, sudden cardiac death is a relief, is a bless. And these devices are stubbornly refusing to leave the patients to die. But this is something else.
Okay, thank you very much, Dr. Panas.